Sunuyu sunacak olan Lynn Verkast arkadaşımızı davet ediyoruz. ECMO'daki kanül seçiminin başarıdaki rolü. Cannula choice for ECMO to ensure efficient and sufficient support.
Good afternoon. Some of you have seen me this morning. The second topic I'm honored to present is something about cannula. So there were just really common knowledge topics, the membrane lung dysfunction, and how to choose, you as a perfusionist, how to put the right cannula in the hands of the surgeon. So a few questions we're going to address: which choices do we have, and how do we going to guide our choice? Cannula selection is so very important, because a good ECMO starts with a good cannulation, and your patient will only recover if he's adequately supported and if you allow the failing organs to recover. So the cannula choice has a tremendous bearing on the ability of ECMO circuit to provide sufficient and efficient choice, and it's you, the perfusionist, who's responsible of the cannula selection. We have a huge variety to choose from in diameters, length, tip design, side holes, number of lumina, coating, shape, wiring, stiffness, price, availability, and regulated use. And some of these I will highlight a little bit. First of all, what is important, and maybe for you in the future, is that the cannula classification, according to the medical device regulation in the EU, it has changed from class 2 to a class 3 device, which means that it needs much more investigation, much more testing for the companies to do to get approval. So some of the cannulas that you work with now, they might disappear over the coming few years. So it will all become much stricter. So according to this different physics of a cannula, we will have a different performance in all this cannula. One of the most important things that you will choose, if not the most important, is the diameter size. We call it charrière, or this is called to this French guy who invented the diameter size. And as he's a French guy, he's semi-French, semi-Swiss, but the French changed the name charrière into French. So we all know the French size is 1/3 of a millimeter, but what is important and why I'm talking about something that everybody knows, the diameter size, it's because the French refers to the outer diameter. So you cannot compare two cannula from different companies with the same French. So that's the first important thing. The new ISO rules, the quality standards, the ISO standards, they ask explicitly to the companies to also define the inner diameter, but on the most information for users, so the leaflet that you find with your cannula, you cannot yet find the inner diameter, just the outer diameter. Then we have a huge variety of lengths, and for adults it's an average 15 to 60 centimeters. And there you have to choose again the length in relation to the patient's size, where you want to put your cannula, where you want to drain the blood, because that's something else, and where you want to return the blood. Then you also have different tip designs and the different amount of side holes. For the return cannula, you have most of the time the blunt cannula and the gun tip cannula, or the semi-lighthouse. That means with a few holes at the very distal end of your cannula. More importantly is the design of the tips or the side holes of the drainage cannula. There you have the choice of a lighthouse cannula. I'm just using these terms because that's what you find in the literature and also if you buy a cannula. So you have the lighthouse cannula, and that's with a tip with a few side holes. Or you have the multi-stage, and then you have a certain length of side holes, or the multi-stage interrupted, where you have a certain amount of side holes, then a size tubing without holes, and then again some side holes, just to be able to select where you will drain your blood. Okay, so you have size, diameter size, you have length, and you have side holes, and everything has an impact on the performance or the flow of your cannula. And you all know, as every perfusionist, you all know the law of Poiseuille, and it's very important. We know that flow is proportional to the radius, this is the biggest part, but also inversely proportional to the length of your tubing. So the longer the tubing, the more resistance, but also to viscosity. Why do I say viscosity? Is because, of course, we always work in blood, but also be aware, if you select your cannula, the information you get from the manufacturers is based on testing in water. So it's overestimated. If you get a certain flow for a certain cannula with a certain pressure drop, be sure that it will be less in real. So you always have to take this into account. At the right side, you see also pressure flow curve of different cannula. And there you can see that cannula who are longer for the same French have a worse performance than cannula who are shorter. So another thing to take into account if you choose a certain size cannula. The longer, there you will lose some of the performance. The ISO standards, again, because of all the confusion, I already said they want the manufacturer to add also the inner diameter to be able to compare better. And also they wanted the industry now to do testing in a realistic viscosity, also to improve the realistic calculation of the flow. If we choose a cannula, we know that we have to respect certain pressures to avoid being too aggressive on our blood cells. So we should keep at all times the suction forces to a limit. And the diagram or the picture at the left comes from a very old paper from 1997. And there's not a lot of investigations done, but we know that if you put pressure, negative pressure on your blood cells, that you will have more hemolysis. Positive pressure is very well tolerated by all cells. Negative pressure is very poorly tolerated. So there we have to keep it at the absolute limit, and we say minus 50 to minus 100. That's somewhere, as long as you don't get this peak excessive pressure, that's something that's accessible or acceptable. Okay, so we know already what we have to take into account. Concerning the drainage holes, you will say, okay, if we have more flow with the more drainage holes, well, of course, we need to take a cannula to drain with more drainage holes. It's something that you should not forget, and that's a nice study who investigated this. The Scandinavians did a lot of studies on the flow dynamics of cannula, and they have seen that the preferential flow in multistage cannula will come from the proximal holes. So in this example, this is a cannula with a flow of 4 liters, and more than 2 liters passes through the proximal holes. So that means if you diminish your flow, less and less flow will go through your distal holes, and at a certain stage, you will even have stasis at your distal holes. So again, very important to take into consideration. If you need a big cannula with a high performance, and you will be okay with the multistage as long as you run high flows. As soon as you wean, you go to lower flows, then you might get into a problem because of stasis at the end. And I'll come back to this later. There's also an impact of the design of the holes, the distance between the holes, the angle of the side holes. If you're interested, you can find some information on this paper. This, what I was saying too, that the drainage holes, if you don't use your cannula to the maximum flow it was designed for, you might have problems. And this paper very nicely illustrates what kind of problems. They had drainage tip thrombosis up to 40%. Most of them in the right atrium, and they can embolize, they can clot make your cannula clot, they can be aspirated and you'll end up with pump failure or oxygenator failure. It might be forwarded and you might end up with pulmonary edema, etc. This can be reduced if you use not a multi-stage, but a single stage or lighthouse cannula, high positioned, high in the right atrium near the VCS. And that's not here, but or if you keep your flows very, very high. Just to say, if you start weaning, be very careful. And if you have to wean in flow, increase your anticoagulation. Also, the incidence of deep venous thrombosis is underestimated, and that's also related to the cannula. Not the cannula only, but the way or the amount of flow you put through your cannula. The very high incidence, more than 50% of your patients have a deep venous thrombosis post-decannulation. So for blood drainage, your multi-stage cannula, which a lot of you will use, they can be beneficial. For the net drainage, you will have the highest flows, but again, your preferential flow will come from the proximal hole. You will have a faster collapse of your proximal vessel, which at the stage of your proximal holes will be smaller than at the distal. So in case of massive hypovolemia or excessive hemofiltration, you will have more problems with your multi-stage drainage cannula than your lighthouse tip cannula. You will limit your central venous blood drainage, so you will have a less oxygen desaturated blood draining to your circuit, because the most desaturated blood is high in your right atrium and in your VCS. And you have the risk, and that's, I said already, of clot formation. Good, so very important, because most of you use the multi-stage drainage cannula, take some things into account. For the return cannula, people go smaller, smaller, smaller, which is okay, because as I said, red blood cells, platelets, they really withstand positive pressures quite well, but don't go higher than 300, 350. But cannula should be smaller than 70% of the diameter of your artery. And if we choose a cannula, we respect the pressure drop. That's the general guidelines of 100 millimeter mercury. And that has nothing to do with the rest of your circuit. So a huge variety to choose from. The 2 lumen, you all know, the double lumen cannula. We can only use the double lumen cannula if we work in series, VV support or right ventricular support. You have different cannulas. They can drain from the 2 caval veins. They can drain from only the superior caval vein. And they can return in the right atrium or in the pulmonary artery for right ventricular support. Then you have coating, shape, wiring, stiffness, but I have no time to go deeper into this, but a lot of interesting things though, to look at. How do we guide our choice? Of course, the level of support, size of the patient, the possibilities in this particular patient, also his pathologies, and of course the surgeon's preference. Keep in mind that you need to have sufficient flow. As I said in the beginning, your patient will not recover, or at least his organs will not recover if you don't support him properly. So, for example, in VV ECMO, this is a paper from Mathieu Schmidt, they state that we should have at least achieve arterial saturation of above 88% with a PaO2 of 60. And then in his study, he saw the flow was the biggest determinant, and you need to be able to achieve 60% of the cardiac output with your ECMO cannula in VV ECMO to start with. If you can't start with this one, that means you've put the wrong cannula. This is a very nice paper. You can look at it, and it really, really defines very well the cutoff of the flow that we need to support our patients efficiently. How do we achieve sufficient flow, big size drainage cannula, and drain at the largest site possible? How do we achieve efficient flow? Is drain centrally, the most desaturated blood, avoid recirculation, and also avoid the differential oxygenation or hypoxemia. There are different terminology nowadays, but just to avoid that you have an upper body that's not very well oxygenated. So where do we put the cannulas? People realize more and more it's not about where you put the cannula, but more where you drain your blood and where you return the blood. So this is a nomenclature paper from a group of the Netherlands, and they specify how you have to identify, if you write a paper, how you have to mark where your cannula is placed, not only where you inserted the cannula, but also where the tip is located and what type of cannula. Because it all has an impact on the efficiency of your support. Because how can we look at our data if we don't know this patient has been supported properly throughout his ECMO? Maybe he has a suboptimal support or flow. So how do we cannulate for VV ECMO? FEMJUG is the most common cannulation. There's been quite some data. This is one of the oldest ones. And the best direction is FEMJUG and not JUG-FEM. That's generally accepted, except in some countries and some hospitals. They do the opposite, and I'll come to this later. There is some recirculation, but it's less than if you would do FEM-FEM. But of course, the dual lumen cannula is even better with regards to recirculation. But then you have to, you're punished with the flows because you cannot give the same flows in dual lumen cannula. With respect to position of the cannula, if you look at this paper, I'm not going into details, but the best return position for the efficient flow is in the vena, in the superior caval vein, and the worst position for return is in the inferior caval vein, which is logical because there is already a drainage. Distance in adults to be respected between the both tips between 10 and 15 centimeters. I said the best direction is FEMJUG, which is a lot of people are doing. FEMJUG, the second most chosen option is FEM-FEM, but in some centers like this is the Karolinska, and they always work JUG-FEM. They investigated which cannula they have to use in JUG-FEM, and they compared a lighthouse tip with a multi-stage tip, and in both they had very high flows, but they had a high recirculation when they used the lighthouse tip cannula. If they pulled the lighthouse cannula back from the right atrium into the superior caval vein, they had less recirculation, but then your vein was collapsing around the cannula. With the multi-stage, you could put him in the right atrium, you could even pull them back a little bit high. There was no effect on recirculation, and also the high flow was maintained. So that's what they use. They have very good experience, and that's what they advocate worldwide. To use JUG-FEM can so work equally efficient with a multi-stage cannula. FEM-FEM, if you use FEM-FEM, most of the time you will put a short fat drainage cannula and a long return cannula. The center who have used it, you see a lot of percentage of the centers, they have to put an additional cannula. Like here, for example, in the swine flu, half of the patients needed an additional cannula because you could not give sufficient support, in contrast with what we see to the FEM-JUG support. You could also go for a long fat drainage cannula and a short slim return cannula. it gives you higher flows, but much more circulation. That's not really done a lot. Also, the same, you can, it's not only important where you put it, but also where you drain your blood and where you return. Again, recommendations from these papers to specify it when you write a paper about efficiency of ECMO support. And that's also an important thing. If you drain in VA ECMO, you can, if you drain too low, you can create two circulations, because the oxygen saturations between the VCS and the VCI might differ more than 25%. And it's even worse when you have poor respiratory function. So if you drain low, you will have a separate circulation which might be much better oxygenated than the upper circulation. So what you have to do is to drain higher. And again, that's the advantage here of putting a lighthouse single tip, a lighthouse cannula with a tip up to the VCS. Or, of course, at the left side, you can also drain from the jugular vein. You will not have this problem. Okay, so if you drain centrally as possible and avoid multi-staged venous cannula if you don't drain to the full capacity. Those are all the tips and the tricks. The last thing I need to add to be complete, and it's far from complete because only 15 minutes I can't be, but distal perfusion cannula, in a lot of centers, it used to be placed when they have problems. More and more it's proven that you should place them electively to avoid limb ischemia. And then at the right, this cannula is already on the market, I think, for 10, 15 years, if not more. But nowadays, some centers start to reuse it because it came down in price, so it avoids the placement of an extra distal limb cannula. But there are, unfortunately, not a lot of data published on the use of this cannula. But the price of one cannula is the same as the price of your two individual cannula you would put in a normal patient, like at the left side. Good, so in conclusions, cannula decisions, drainage cannula, big, you drain centrally, only multi-stage if you need it with respect for the flow, and you need to respect physiological working pressures. Return cannula as small as possible to try to save your distal limb, respect physiological working pressures, and keep distance between in and out in VV ECMO. And very importantly, that's why I give this talk for perfusionists, make sure you know your cannula, you know what you have to give to your surgeon. You arm yourself with knowledge. Okay, thank you very much. If there are questions, I'm always willing to take questions, but I do not understand Turkish. I don't have.
Okay. Thank you very much, Lynn, for your detailed presentation. The questions will be at the end of the session.
Okay.
Okay, thank you very much. And the second presentation will be online. İkinci sunu online olacak. Adrian Bauer gelememişler. Avrupa'daki perfüzyonistlerin yeterliliği, genel bakış. Compatibility of perfusionists in Europe. Bağlayabilecek miyiz arkadaşlar? Tamam.
Yeah, dear ladies and gentlemen, thank you very much for the invitation and the possibility to present our expert consensus statement here in Antalya. And Üskünün, that I'm not going to be there because of several reasons. Yeah, dear ladies and gentlemen, thank you very much for the invitation and the possibility to present our expert consensus statement here in Antalya. And Üskünün, that I'm not going to be there because of several reasons. I have a lot of sick leaves in my clinic. I'm not able to come, and I'm very sorry about that. Yeah, my name is Adrian Bauer. I was part of this fantastic project to write a consensus paper, and I will guide you through why we have done that and what could we do with that paper in the future. And I want also to thank you, my co-chairs, Alexander Weber and Gudrun Gunst, for doing that paper together with us. That means that the cardiac surgeons and the cardiac anesthetist was in that consensus on board. Thank you very much to all the people who contribute to that paper. And special thanks goes to Milan as the guideline coordinator of the ERCTS. He have done a wonderful job together with Julia to guide us through that guideline or to that consensus statement. Thank you for that. Why we have done this, or what was the reason to doing this? What was the motivation? First of all, this is an expert consensus document. That means several parties was involved in that paper, and it was contacted to the ERCTS methodology, what helps us a lot to set up a certain paper in that manner. So it's intended for the hospitals. That means you, as those one working in that hospitals. Nevertheless, whether you are a surgeon or a perfusionist or an anesthetist, you can use that paper to know what you can argue for, what a perfusionist should be. And that brings me to the next point, to the universities. We try to give them an idea what we as clinicians expect from a student coming out of a program, what competences, what skills should a perfusionist have when they enter into the perfusion field. And last but not least, of course, we can use this recommendation for argumentation also for the, and even for the policymakers, to show them, look, there's a profession, and that this profession is very clear described, and you can recognize that profession based on that document, for example, and of course other things. We reached, I just show you, more than 90% to all the statements what you see in that paper, which is a great result. It's necessary to have more than 75% of the votes for a certain statement, and we reach for all the statements at least more than 90%, which is a good result. So what have we done? We described the field of perfusion and therefore what a perfusionist is. And you all know, and that's exactly what we are doing in the middle of everything, is the heart-lung machine, is the cardiopulmonary bypass. And that would be that thing what we not share with others. So to use, install, to have the responsibility for a cardiopulmonary bypass, it's the origin perfusion field. But you also know that we need a lot of more competencies now. When I start with perfusion, I do more than 90% of my workload with cardiopulmonary bypass. But now it's more and more diverse, the field. We have to look to new fields, to new competences, and that's why we also describe facultative skills and competencies. And that's all surrounded by different sciences, the health sciences, engineering sciences, but also, and that's very important to mention, the patient care. The patient is the most important thing, what we have to look for. And interdisciplinarity, it's behind my head. So is, of course, one of the challenges for the future. We will work not only with cardiac surgeons and cardiac anesthetists in the future, we will also work in oncology and other fields, vessel disease and so on, and have to be open for that new things. We described evolution of the profession, even in regard to the different societies coming up. We described certain milestones in that paper. And we also discuss a lot the situation that we have in Europe. And the situation is that we have a very diverse healthcare background for all the different people working in the field. We have allied healthcare professionals like nurses. We have medical technicians, also engineers. We have technologists in healthcare. We have medical doctors, even in the East, sometimes also in France, for example. And we have persons or people with different other professional backgrounds, like degrees in biology, physics, or health sciences. And if you look at that map here, you can see that a little bit. We have the allied healthcare professionals, the technicians, we have the medical doctors, and that's very diverse. And that's the reason why we have to describe exactly what a perfusionist is, to get all the backgrounds in one profession together. So there's a definition of a clinical perfusionist. It's not the first definition on it, but it's the current one, if you want to. So it is a healthcare profession. So that's the first thing. It must be an academic training, and we are part of the cardiac surgery team. We are responsible for performing and monitoring the CPB, but we are also responsible for other medical devices. And we are looking forward to new things like organ perfusion. You see that in the third part here of the definition, for organ perfusion systems, ex vivo systems, normothermic, extracorporeal perfusion, HIPEC, and so on. That the new field coming up, where the perfusionist should be able to do that, and that means also that the university should have that in their curriculums and syllabuses there. We're talking about the qualification regarding the academic level, and the academic level should be at least an academic degree with 60 ECTS points, and that helps us. For example, I'm also the chair of the accreditation committee of the European board. That helps us if we are going to a certain university asking for to be accredited by the European board. Then we can say, okay, at least you should have 60 points. If you have more, that's fine, but that's our bottom line. And that helps us to accreditate schools in the future. We have a long discussion. Should we have a master degree recommended for perfusionists or not? I can tell you, for example, in Germany, we have a lot of people coming into the profession without a bachelor. That means that they then doing a bachelor in perfusion, but in other countries, a lot of healthcare professionals coming already with a bachelor into the study. So that means after a discussion, we decide to recommend the master degree for perfusion and give those countries, for example, Germany, time to develop this forward over the next 5 to 10 years to have a master degree in place. We are also talking about clinical training and the requirements for it. And it's very important that you have your education period in a clinic according to a certain circumstances. And that's dedicated to the ESCTS description of a cardiac surgery department. You have to go through an oral exam, you have to go to a practical exam, and you have to have the use of a logbook. And in our case, the European board logbook, and that means at least 100 perfusions before you can sit the practical or also the theoretical exam. We're talking about in that paper competencies and skills. You need certain technical expertises. You need interpersonal skills. I come on that a little bit later on. And you need optional skills and competencies. The technical competencies could be, of course, or should be, must be, the knowledge of anatomy, physiology, and so on. But we also include new things like data interpretations, data sciences. So that would be the future, to work with big data to improve perfusion. And therefore, that is also recommended for the study when you are going to be a perfusionist. This critical interpersonal thinking, problem-solving skills are very important. You, as perfusionists, have to make sometimes rapid decisions. Like, for example, if your oxygenator failed in the middle of the night, you are the only perfusionist in the room. Then you have to decide, will I change it out or not? And that have a big impact on the development of this case, of this patient. And that's exactly the competence what a perfusionist should have. And if you look what a master should have as competence, then you will find exactly such things. Sometimes you are sitting with a team of 5, 7, 8 people together for hours, a type A dissection. 8 hours, 10 hours, you're in the room. You need that interpersonal qualities. It's a little bit like the astronaut. The most friendly people on the world are astronauts. You know that probably. That means to have the right background and the right personality to work together with a team, strongly together over time under high pressure. It's very important for a perfusionist. We are talked about facultative skills, and that could be and should be, of course, that new fields, organ transplants, organ perfusion, oncology, vascular operations, and of course also for those one who's going to treat kids, then pediatric perfusion as additional skill on top of the regular education. So we also described different levels for experiences. Junior, mid, and senior perfusionists. A junior, for example, is up to 500 perfusion or up to 3 years. Then the mid-level comes, and the senior have more than 3,000 perfusions already. Then he can call himself as senior perfusionist. And a chief perfusionist should be a senior. That means that you should have a certain experience before you lead a department. The healthcare profession, perfusionist, is an integral part of the medical team and must be independently contact the CPB within the standard operating procedures in the clinic, and of course in collaboration with the cardiac surgeon and the anesthetist. And these SOPs are very important. That's your law, what you have, your regulation in your clinic. You have to sit together and you have to describe who is giving drugs or who is not giving drugs. We can't during the bypass. We can't recommend that here in that paper, but we can say, please regulate that in your clinic at your level, and that will be done over standard operating procedures. Last but not least, we want to go forward to the European Union for the recognition of the profession, but before we have a lot of homework. We have to harmonize the schools. We are not on the same level across Europe. We have to harmonize the schools at the same level. Then we have the same perfusionists, and with that same perfusionist, we can go forward to the policymakers and ask for recognition of that profession. So that's all depending on you, on me, on all of us to improve and to harmonize our field of profession. Yeah, the perspective would be more academization and harmonization of the academic training. Perhaps in the future, we will expand, and we have to expand the role and advance the technical skills and the knowledge of the perfusionists in the future. We have to promote more simulation, using of simulation. And last but not least, we have to raise up the academic level of clinical perfusionists to the master level. And then we will have, I don't know, regular rates are 10 out of 100, 10% are probably also doing a PhD. It's not necessary to have a PhD to run a perfusion, but it's necessary to have a PhD to describe the field, to have perfusion science, to build up perfusion science, and to be strong as perfusionist community. Yeah, therefore, that's a good development, I think, and we should going forward in that direction. Once again, thank you for your attention. Thank you to all the people contribute to the paper. And let me say, we are a very small profession. And so 3,000, whatever, in Europe, 650 in Germany, that's nothing compared to other professions. And therefore, my message is, we have to stay together. We have to work forward with what we are doing. And we cannot do it alone. We can only do it together. Thank you very much for your attention. And hopefully see you in person in the future. Thank you.
Thank you, Adrian Bauer. We wished you were here in Antalya with us. Thank you for your contribution to the Congress. Teşekkür ettik tekrar Adrian Bey'e. Bir sonraki sunuya geçiyoruz. Pediatrik kalp cerrahisinde kan koruma yönetimi. The next presentation, blood product management in pediatric cardiac surgery. Norman Sikora.
Okay, dear ladies and gentlemen, dear chairman, let me present another topic I have prepared to talk about. In my opinion, it is very, very important topic, not only in pediatric cardiac surgery, but also in adult cardiac surgery. In my opinion, we use far too much of blood products in cardiac surgery, and we must do efforts to decrease the amount we are actually using. And pediatric cardiac surgery, it's always associated with significant perioperative blood loss. And this, of course, frequently leads to blood product usage. And therefore, especially in pediatric cardiac surgery, blood conservation and all the strategies we can use is a very important issue we must keep in mind. And first of all, we talk about CPB. And for children with congenital heart disease, it is a very unique challenge if we talk about transfusion practice, because overall need for transfusion of blood products is much higher if we talk about, if we compare with adults, because bleeding risk is much higher for small children. And let me have a look at reasons. And first of all, of course, for those who works with children know that we have a very huge problem, hemodilution. Because we use prime volume, and prime volume can sometimes exceed the blood volume of neonate even by 200 to 300%. In addition, we have immaturity of the hemostatic system children has, and at the end of the day, we have actually smaller relative size of the patient with much higher metabolic and oxygen requirements. And these patient characteristics increase incidence of complications, and if we see complications, they're much severe if we compare with adults. Therefore, it is very big, the management is very challenging for children if you talk about blood products. And anemia tolerance, bleeding risk, and transfusion treatment is directly dependent and influenced by such things as patient age and weight, surgical complexity, how long is the operation, degree of cyanosis, and also coagulopathies induced by CPB. So, why it is very important to avoid transfusion of blood products? And what I always teach to my students is, this is nothing good. We don't want to use blood products in our everyday life. And let me have a look at the problems we can cause. So we have a lot of different transfusion reactions associated with these blood products, and they are classified in different groups. Like we have acute, immunological, and we do have here hemolysis because of our mistake we are doing. There is also febrile because of admixtures of leukocytes we have in blood products, allergic, and also a very bad reaction, which is called TRALI. Then we have also acute non-immunological, like bacterial infection, TACO reaction, physicochemical hemolysis. And we have late immunological, again, hemolysis. And this time we talk about also graft versus host, which is caused by lymphocytes in blood products. And post-transfusion purpura. And late non-immunological, we have such things as hemosiderosis and blood-transmitted diseases. And if we have a look at the most common risks associated with blood products, this is by all means infection risk, the most important. Also, we have respiratory, cardiac, and renal complication risks, increased ICU and hospital lengths of stay if we use blood products, and also inotropic scores are increased. And we can say actually that increased volume of red cells in CPB prime or during CPB often itself leads to excessive postoperative bleeding. And risks can be classified also as infective and non-infective. And if we talk about, in particular, children, the vast majority, of course, would be the non-infective causes seen in pediatric cardiac surgery. Okay, is there anything we can do actually to reduce the number of blood products we use in our everyday work? If we have a look at this paper, these authors conclude that the approach must be always multidisciplinary. And we have blood conservation strategies, and these strategies can be divided in 3 groups. We have preoperative, we have intraoperative, and we have postoperative. So, preoperative, it means that we do things already before operation. So we have to carefully assess patient risk factors. We have to test patient for anemia, iron deficiency, coagulopathies, and if we find them, we have to correct them already before operation. Then it is possible to use preoperative erythropoietin and iron supplements. If the patient uses aspirin, it's a must to stop it at least 5 to 7 days before surgery to get back in normal count platelets. And at the end, actually, if we have quite big patient, we can always advise for this patient to go and donate blood for him or herself. We can use during the operation. Now let us have a look at intraoperative strategies we have, and everything starts, of course, with surgeon meticulous skills, which can shorten itself CPB and hypothermia time. And also it's very important for surgeon to do perfect hemostasis. It's quite logical. Then if we don't see bleeding after operation, we would not use blood products. Now let's have a look at the CPB. So the first big problem I told you already is hemodilution. And at the beginning, some time ago, it was thought that hemodilution has benefit things, like it itself reduces red cell transfusion requirements and improves microcirculation. But then they observed that there is increased incidence of postoperative cognitive impairment if we have too low hematocrit. So then the question appears, what's the good hematocrit in CPB for children? And it is suggested that goal hematocrit during CPB must be over 25%, which is necessary for optimal neurodevelopment. And most often authors recommend it to keep it between 28 and 30%. In order to limit hemodilution, of course, the most important thing is to optimize CPB, as my colleague already talked about adults before me, but also for children, it is even more important to do as small circuit as possible. We can replace CPB pump circuit volume with patient's own blood, and at the end of the day, we can use also vacuum-assisted venous drainage to improve venous drainage, and we can use in that way smaller cannulas. Next thing CPB-related is hypothermia. We use quite often in the pediatric CPB in order to reduce cerebral metabolic rate and in order to protect internal organs from ischemia. But hypothermia kills platelets and decreases enzyme activity along coagulation pathways. So at the end of the day, we have again increased risk of bleeding. In CPB related, we can talk about ultrafiltration, which is a very good method to limit hemodilution. And we have 2 types of ultrafiltration. We have conventional, we have modified. But in children, modified is much more popular because with modified ultrafiltration, we decrease not only edemas, we decrease quite a lot of activated inflammatory mediators and we can improve hemodynamic status of the patient. Heparin management. So, of course, we use all heparin in CPB, and for children it is also a bit tricky because we have age-related differences of heparin sensitivity and heparin-protamine interaction, so dosing is very challenging. We know that we use protamine to reverse heparin's effect, but we must not forget that protamine itself, when it's too much given to patient, can increase bleeding risk. And the last but not the least, we have also post-operative methods like antifibrinolytic agents. We can use, for example, tranexamic acids. Then very popular methods, very widely used in pediatrics is, of course, cell-saver devices, which is very safe and effective in order to reduce blood product transfusion. And very important thing, we must limit sampling and blood wastage for children in IC unit after the operation in early post-operative period. I mean, this is nothing new in pediatric IC unit that we sometimes use too much of blood we take too many samples for lab testing, and of course, child has much less blood inside its organism. So we must think about it, how to reduce this. Do we have any evidence-based guidelines available for children? Unfortunately, we don't have. We have only adult guidelines, but I certainly do believe that we can use a lot of these guidelines also for pediatric patients until we get our own guidelines. So, to take home messages, not a lot. Try to avoid blood products in cardiac surgery at all. Not only pediatrics, but also adult. One more time, I do believe that we use too much of blood products. And in order to avoid blood product usage, or at least decrease usage, we must use all blood conservation strategies I showed you before. And with this small patient, I would like to thank you for your attention and for inviting me here to speak about these important things. Thank you.
Thank you very much, Normus Sikora. And now we'll go on with the discussion. Do you have any questions? Sorularla devam edelim arkadaşlar. Bingöl Hocam buyurunuz.
My question is to lead to first speaker. Once we had aortic dissection from groin up to the aortic valve, when we are doing a percutaneous femoral cannulation. Have you ever had this sort of problem, which was a disaster? We lost the patient. We put the cannula into the urinary artery, but we couldn't save the brain, so we lost the patient. Do you have any more idea to save the patient if you have that sort of complication?
I think it's a complication that you cannot avoid, and the trick is not to avoid it, but the trick is...
And we noticed the problem when we went on bypass.
Yes, the trick is, and that was I was going to say, don't go on bypass. And that's why, and that's illustrated in the papers, we should use more centrifugal pumps, not only for long bypasses, but for bypasses in cases like this, where pressure off is very important to monitor. With the roller pump, you just go, you do, the damage is done. With a centrifugal pump, you will not have it. So this is something that, we had this in the past, we use centrifugal pumps, and we managed to save the patient. But if you just start pumping, you probably will, unfortunately, be too late.
Thank you very much.
Thank you. I have a question for both Adrian and Normans. I'll start with Normans. Do you think the age of the red blood cells are important? Because I missed it, but there are some studies where they state that the older the red blood cells, and well, it's a fact, the more rigid and they are, and the less suitable they are for oxygen delivery and uptake. Do you think in children this is even more important? Do you look at it? You have a policy?
Sorry, Lynn, it's too big echo. I can't really understand you.
You let me talk for 5 minutes and then you say you don't understand me? No, you think the age, the age of red blood cells is so important with respect to the TPG2-3 content and uptake and release of oxygen, and also deformability. Don't you think in children it's even more important? And do you look at it? Is there a policy that you say the red blood cells should be younger than 3 weeks or something?
To be honest, Lynn, it was the topic a long time ago when I was a PhD student. I did research on it, and that was not very big research at that time. I took 80 samples of red cells we used in pediatrics, and I realized that in day 5, it's a remarkable increase in such things like potassium, lactates, and decrease in pH. And is it important for children? I mean, if you put something like that, if you transfuse something like that directly into the child, it's going to have a lot of problems. Like I read some case reports when this extra potassium in these red cell packs, which are old, actually stop the heart of the small neonates. But for CPB, actually, we do, we prime these red cells, and we leave them to circulate for some time. And then it's much better.
And
yeah.
Yeah.
I use Terumo. I use Terumo, and after some time, yes, potassium also go down, and we can see that. So it's if you use not very fresh red cells, you must circulate them before and oxygenate them.
I was also hemofilter in the prime.
Well, no, we don't filter at prime. That's for sure.
Because always we are adding the hemofilter in our circuit. So when I always check my prime, if anything wrong with the blood gases and the
It's very good idea. Good idea. But of course, if you can choose, then it's better to use very fresh red cells for children.
Yeah, but there is no.
Yeah. Not always it's possible.
Yeah, in Turkey they can use. We used to use in here daily. Their family comes and gives the blood. We were using the same blood for our prime. Here in Turkey.
Yeah, but then you probably irradiate them also. Because if you use parents' blood, you must irradiate.
No, the cross-mass check or the relatives, cross-mass checked previously, they are ready to give blood on the same day when the patient is going to be operated.
It's a very good idea, of course.
Thank you.
I have a question also for Adrian. You know, in the nursing world, we have a big shortage of nurses, and in Germany that's no exception. And therefore, our head nurse positions, they tend not to be persons with 20, 30 years experience, but they tend to be managers, and sometimes quite young, but they have their master's degree. But so you define head perfusionist as somebody with extensive experience and a master's degree. Wouldn't you be a little bit more careful in defining this, because you are excluding younger people and people who have just management functions, and maybe in a world where we have a shortage of clinicians, we can leave the management up to other profiles?
Yeah, thank you for that question, Lean. And indeed, we have also that discussions. Even we have also, I want to add another argue against having masters. The argument is that probably masters earlier leave the profession, going to the industry or take other positions. But I will argue against that. I think as higher the level of a profession is, as more attractive is that level or is that profession. And the only thing what we have to make secure is that the university programs runs good, and that we have enough output out of the universities. And then I'm sure we will get that people, first of all. The second thing is a senior perfusionist is defined by 3 years, which is not long. If you imagine, or if you say you need 5 years to study for a master, then probably you are 23 or 24, which is quite young. And the second thing is that then you make sure that you have a really experienced or experienced person in that position, and even to lead a department is You need people with a certain background to have a strong standing within the clinic. And I think that's, and at the end, it's only a recommendation. So that means not, it's not a law or something. It's just a recommendation for us.
Yeah, I can add something more. When we prepared this paper, Adrian was our big team leader. We had a lot of discussion about it, and I said in eastern part of Europe it's going to be nearly impossible to get master degree. So we state as a recommendation we want to do it within the next 10 years, but I mean this is only a recommendation, as Adrian said.
Yes, we are already late, and I want to close the session. If no other questions. One last question please. Son bir soru. Sonra oturumu kapatıyoruz arkadaşlar. Zaten geç kaldık.
Adrian, thank you very much. We know European Board did a very good job for the competency of perfusionists. During this journey, what was the surgeon's opinion about the competencies of perfusionists?
Yeah, I was really surprised that they are really open. We discussed always on an eye level. I don't have the impression that they don't want to have us strong. I have the impression that they are very happy to have experienced and a well-trained perfusionist beside them, because they recognize if the bypass, the cardiopulmonary bypass, is done well, then it's a big contribution to the success of treatment for the patient. So the collaboration was excellent, I can tell you.
Yeah, very nice. Thank you, Adrian. Greeting from Antalya.
Yeah. Have a nice congress. Bye bye.
Bye bye, thank you.
Thank you very much. Çok teşekkür ediyoruz. We close the session. See you next session. Thank you. Bir sonraki oturumda görüşmek üzere. Teşekkür ediyoruz.